Good afternoon, everyone. Today is Friday, December 3rd. This is United Medical ACO, our updates for Delaware Health and Community. So we will be covering COVID-19 updates, and we do have a couple other stuff. So let's actually start the session. So while we are doing that, I just want to make sure that everyone actually gets the hold on one second. All right, so Sean, you can introduce yourself while we are doing this.
Sure, yeah. So again, I'm Sean Dunnigan. I work here in the business development team. I work underneath John and Kosivi, and part of my role here in our UMACO live session just kind of to give us updates here on our COVID status, both the infection rate as well as our vaccination updates. So that includes both the booster shots that we have going on, as well as our pediatric population that has recently become eligible to receive their vaccinations. And then this week, specifically, we're also going to touch a little bit on the Omicron variant that has emerged recently.
So, Sean, since the last time we were up here, that's been 2 weeks.
Correct.
So we did have, well, the COVID is now part of our life. It became part of our life. So it's kind of interesting in a way. When I do the case conferences, in our power chart, if the patient have COVID diagnosis in the last 30 days, it just gives you an alert when you go in and just tell you like how it became like so normal for us. I used to freak out every time I see that. Mm-hmm. Yeah. Now we're like, oh, okay, patient has COVID. So that's like, they have like 10 more days or 5 more days. So it became one of those, but this doesn't mean that it's not problematic, which now going into the winter season, it is becoming more and more problematic. So we want to make sure that we can provide our updates and people will be prepared, right? So now, just to start with what we have globally, United States still has the highest number of cases, daily number of cases with 83,000. Like Germany, United Kingdom, France, and Russia comes after. Now, when we look at the number of people who lose their lives, Russia with 1,229, then United States. Now, these numbers, I know that India number is definitely not accurate when we look at these from that point. But now, if you can give us what we have in terms of the vaccination in the United States, so we can start from there.
Yeah, so this slide that's actually up right now for the viewers is the cases in the US that are being reported. So again, we did see that a larger spike at the end of the summer, not August. And then, now recently with the Thanksgiving holiday, as we approach the winter, Christmas, New Year's, we're expecting people to be interacting, traveling more. So we're going to anticipate, a higher spike, especially the winter months are going to be indoors, close quarters, close interactions with people. On our following slide, though, we do have some of the global vaccination update. So again, it has been 2 weeks since we did touch on this, since we were off last week for Thanksgiving. But as we see here, Cuba is still on the top. Important to note, though, that the US is not in this top list. So I think we said it was 15 countries or so is mentioned here. Yeah. And again, US is still not going to be in that top 15. We do have, though, on the next slide, little bit.
I think part of the issue we have is our daily number of vaccine given to people, right?
Yeah. Now with the booster being available, it is going to obviously increase since there's more vaccinations to be able to be administered. And again, also with that pediatric population now being included. Also, as we do touch later on, we did mention, hopefully we'll get to it this session, that there's now boosters that are pending approval. I think actually did just get approved for 17, 18-year-olds around that age, maybe 16, 17, if we touch on that later. So again,
17, yeah, it is 16, 17.
Yeah, so again, the more population we have that are able to receive these boosters, obviously we're going to see the numbers overall in that uptrend for sure. And then, here is just the US if you have an overlook on this, now we're up to around 197.5 million that are fully vaccinated. And then if you do look right below that, are approaching 42 million with, like I said, receiving those booster doses. Something to keep in mind though, now that obviously we have new variants coming out. So will there be variant in the vaccinations on which, COVID variant it's most effective against, or if you'll have to receive different boosters, to keep your immune system the most up to date as this virus continues to mutate. So just something to keep in the back of our minds there.
Definitely. Now, when we look at the U.S. numbers, and then from that, when we look at the Delaware, this is our home state. So the vaccine numbers are slow right now. Like we are, you practice 2 weeks versus this week comparison, and when I look at that, only like 7,000 more people in the last 2 weeks fully vaccinated. So that number is really low, right? So we want that number to be like when I look at here, this is only 540 and I'm 547 here. Now there may be some reporting issues, but I would definitely expect this to be better.
Yeah, it definitely appears to be crawling here, coming to a slowdown. Like you said, it could be reporting issues, say with the holiday, if, people are off, having that Thursday, Friday break off, may not be as up to date as you would like, but definitely just overall, you see the trend of it starting to slow down, and you're definitely expecting, hopefully, a larger increase over a 2-week span than just roughly 7,000 right there.
So Anthony Anugu, our director of contracting, did contact with, I think it's reaching out to state medical director. We do want to actually see how we can actually help them during this process. I believe there are still a lot of people who's eligible and who's not getting, or who they may not know to get vaccinated. It may not be available to them. And if they definitely don't want to do it, that's understandable, fine. But we want to make sure that we can reach out to people who are in need of vaccination. Now, Sean, one of the things that I find out when we do our case conferences, those case conferences are kind of eye-opening for us. When we make some assumptions in terms of what the patients should have and should not have, what they should be getting for, like with the quality metrics that we are looking for, this cookie cutter approach or method of population health is not the best way to manage these people, these patients. There are really different group of people who need different needs. The transportation is a huge issue. The food security is a huge issue. And when we try to get them to the lab for blood work, and then when in some cases these are elderly, some cases these are younger population, they may have different responsibilities or different challenges. And I do believe that with the vaccine outreach, the state should be able to do more outreach to help these patients. Now, we are definitely willing to be part of this and try to help the situation, but it seems like we are still a little bit on the slower side so far, and I'm hoping that we can do a better job. Now, we will have a couple of guests joining us later on, so while we are waiting for them, I do want to cover the Omicron, right? The new variant. We discussed this in the last session 2 weeks ago. And since then, we have our first confirmed cases in California, and the second one is in, was it Michigan?
Yeah, I think it was either Michigan, Milwaukee.
It was on the West.
I mean, by now, there's probably even more.
It's more, yeah. It's more.
Yeah, so in real time. But yeah, it was definitely expected, that the scientists in South Africa, notified the WHO once they did discover that variant. And I think also I read in some of the articles that they believed it was also maybe like the Netherlands or somewhere that they also thought it was present prior to that. So, it was only a matter of time until you'd see it pop up here in the US. And in the initial article, it said that the person did travel back. I think it was November 22nd or so from South Africa. They were quarantining, but it was identified it was that new strand, the Omicron that we were discussing here, is that new variant. So, like I said, only a matter of time to see it popping up.
And one of the things that we know that this is happening is because the it actually did the variant got stronger in the unvaccinated population.
Mm-hmm.
So as that's more, I guess, convenient for this variant to become stronger, because normally when these mutations are happening, that's every time it happens, it gets weaker. But as it's happening, if it learns new stuff, then it can actually become a different one. And then this is why the vaccine is important, because it will keep the spread in control, and then it will actually help everyone. And I think one of the things that we have in our updates is the variant linked to the vaccine inequality, right? So this is
the vaccine inequality that was discussed. Obviously, they believe that's kind of what brought about this surge in the rapid mutation, and then the fact of its transmission rates too. They say that overall, the wealthier countries, the richer first world countries, obviously had larger doses and availability and means of administering vaccinations to their population, whereas some of these maybe poorer off and third world countries who didn't necessarily have the same access or availability. The reason being the variant emerging is because with less overall other population getting the vaccine, that allowed for this mutation to occur. Whereas, in some of our slides later, we'll talk about herd immunity, where as long as you have a certain threshold of the population, it doesn't really allow for that mutation to happen in the first place. So that's kind of what they were talking about here with the inequality being the vaccines dispersed over the wealthier, richer countries, sort of not necessarily hoarding them, but just their availability and accessibility to them, whereas opposed to the poorer off third world countries who obviously are not going to have the same availability and rates to administer it. So kind of the whole idea here, overall message, is that we want everyone to be healthy as a global effort, not necessarily our country versus theirs, but we want everyone to be healthy as a whole.
Unless we stop traveling,
mm-hmm.
Right? So that's not happening anyway. So now this is also kind of it brings the herd immunity issue back on the spot. So because we were talking about this a lot in the beginning, but now it's kind of like, as we are not reaching to 75%, I guess it became less important for those, but it is part of it, right? So like if we can go over that a little bit to see why this is again important from the spread standpoint, and then how we can actually keep this under control.
Yeah. So if we look here, we have this visual aid. Maybe a little bit hard to see, but basically the blue people are going to be representing those who are not immunized but are still remaining healthy. So they didn't get a vaccine, but they didn't contract this COVID here. Whereas the yellow is going to be those who are immunized. So that means they got their vaccination and they're also still healthy. So not contracting COVID in this case. However, the red ones are going to be the ones who are not getting their vaccine and are sick and contagious. So with this visual here, we're going to look at this top graph, and the point being is that if the blue people are not getting their vaccines, they're going to be, at risk to contract this virus. So from the red ones interacting with them, you're going to see more of that blue healthy population who are unvaccinated are going to, contract this contagious disease, and then overall you're seeing it spread throughout the population. Whereas that middle graph kind of shows, a little bit of the people in that yellow have that vaccination. So a little bit of them in the after photo on the right there, they are not going to be contracting that, the COVID. Whereas the very bottom picture kind of shows you what happens when you have a larger amount of the population getting that vaccination. So this is kind of that herd immunity, where once you reach a certain threshold where enough people are vaccinated, it's not going to be as contagious and not going to be spreading from person to person at nearly as any rate as that it would with a largely unvaccinated population. So that's kind of what this herd immunity is trying to push here, is the idea that once a certain threshold is met, the entire population overall is safer because less people are going to be transmitting that disease from person to person. So the thing here that kind of relates to that vaccine inequality is the fact that, yeah, maybe a large population of the richer, wealthier first world countries are getting vaccinated. But if you look at, on a global perspective, if there's certain countries, say third world, that again aren't having access to these vaccinations, they are going to be the ones that are now transmitting the disease, contagious from person to person. And that's where we wanted this herd immunity to kind of be seen on a global level, where it's made available to everyone.
So, but that vaccine actually is not what we learned by now. Not being vaccinated is not related to the rich and wealthy, because in the U.S. population right now, we are at only that 70%. Since the vaccine became available in December 2020, in like 1 year, we there are still more vaccine available. All we could do is 7%. So, and the other 30% is not vaccinated because they don't have access, right? So we actually have this issue of, this is not about the money anymore. This is not about the wealth. So this is about whether or not people trust the system or trust the disease. I mean, there are still some people don't believe that this is a real disease. But regardless of what happens with that, one silver lining from this pandemic is telemedicine and utilization of telemedicine. Yep. I have, and I always say this in our sessions, I have to both my parents, my mom and my dad, one in his 80s and the other one's in her 70s, my mom. And like one thing is I tell them, unless you have to be somewhere, don't go. And if you have to, then keep your mask on. So and then try to do telemedicine as much as possible. So those are the things that I think maybe what we learned from this. And now our practices did not actually stop utilizing telemedicine even after the vaccination being available. And for our next topic of Medicare population, especially, like I can emphasize this enough. If you don't have to be in the office physically, insist on telemedicine. Try to set up your home for telemedicine so that you can actually have a good experience with telemedicine. So now I think our two guests, they are now available. Dr. Marikar Belisena, actually, she was so nice to accept our request because she's seeing patients right now, and she was able to take time off from her patient hours, and then she's with us right now. And then also we have our Director of Clinical Integration, Donna Gunkel, with us. So I'm going to ask first Donna and then Dr. Belisena to introduce themselves.
Hi, good afternoon, everyone. Again, I'm Donna Gunkel, and I'm the Director of Clinical Integration here at United Medical ACO.
Hi, good afternoon. This is Dr. Belisena. I'm a primary care physician, internal medicine here in Bear, Delaware.
Dr. Belisena, thank you so much for joining us, and also Donna, as usual. Now, we do want to discuss this topic of, and I'll tell you, maybe we want to make sure that we get the most time out of you, so I can save my comments to the later time. But with our Medicare population, urinary incontinence and the fall prevention are the two problems that we are always having issues with. And then many people don't really understand how important this is. And some patients, they are not comfortable bringing this up. And we wanted you to kind of help us with what patients should know, how they can bring this up. Again, this is for our main focus for today is more on the elderly population for Medicare. How can we actually address these issues? And then from the clinical standpoint, how you are actually dealing with these and so on. So if you can kind of maybe explain us what this is, like we can start with the urinary leak.
Yeah, so there are many reasons why patients encounter this incontinence, whether they're leaking or whether it's just related to certain activities like coughing or exercise. So mainly when I deal with these issues, it's pretty much on their Medicare wellness exam. However, it also comes up when they are having symptoms like, they say that they're leaking, or when they're coughing, they have a little bit of leak. Or one of the things that I really ask them during a wellness exam is, do they wake up in the middle of the night to urinate? And because to me, that's a safety issue more than anything else. The reason for that is, of course, during the evening, just because they're sleepy, the area can be dark, it's not well lit, they can fall, trip, and basically break their hip. So that's really a safety concern more than anything else. And then when it comes to the different kinds of urinary incontinence, it really, to them, it's really not an issue. It's basically for the providers to say, okay, because of what you're telling me or what your symptoms are like, then this is the way to go. Whether it be a Kegel's exercise or whether it be medication, or whether it's just been training, like, okay, before going to bed, let's say, what time do you go to sleep? And they say, okay, maybe 11 o'clock, 10 o'clock. I'll say, okay, so if you sleep at 11, go ahead and maybe last drink should be at 8 o'clock. And then even though if you don't feel like urinating or peeing before going to bed, just go urinate. So then the hope is they won't wake up in the middle of the night to urinate. So that would be how I would address these kinds of situations. And with regards to, there's different kinds. There's stress, there's urgency, there's overflow, and those come with a certain type of diagnosis. And most common cause of incontinence is overactive bladder. And women most commonly will experience this, but of course men can do that. But of course, for men, it's most likely due to prostate issues. And that comes when they're elderly. The other thing with women is when they're too busy taking care of the kids, they hold their urine, or they're working too much, and before they know it, they forget to go to the bathroom. And sometimes that's what happens, and then they cause some incontinence with that. So it's just basically educating these our patients and say, okay, what's the situation? When do you have these problems? And to address those kinds of issues when they come up.
So, Dr. Belson, do you feel like if the patients are having a difficult time to bring these issues up, and then I have the same question in a different way, do you sometimes feel not for you, maybe personally from the clinical side, do you feel like sometimes primary care physicians, maybe they're not bringing this up unless the patient says something?
Well, from my personal experience, it's not a problem for me because that's part of the review of systems. That's part of, I ask, do you have issues with urinating? Is it painful? There's blood, there's pain. And do you urinate? How frequently do you urinate? So that's part of the review of systems. That's, part of the physical exam. And not only that, let's say they come in and they have issues. Let's say they have urinary tract infection. So you want to say, okay, when was the last time you've had an infection? What's the situation? What are your other symptoms? And so I guess with women, for me, it's not a problem. The other thing too, I would maybe on the EMR side, it would probably be helpful sometimes because sometimes I have to look around where the urinary symptoms are, and it's easy. Probably would be on the banner, so then it's right there, and it's a good reminder for us to say, okay, you need to ask these things, especially with the elderly. But that's part of my Medicare wellness when I ask patients.
So from the elderly standpoint, and I say elderly, but this is now 65 and over, the population we are talking about.
Mm-hmm.
I really shouldn't say elderly for 65. So now the overflow, and this is the functional, right? The functional incontinence. So these are the two most common. And now this is the one with the disease related, such as diabetes, and this is just from the age. Now, from the treatment side, now what would be the best way to, like, what is your choice of treatment when this happens, either from the overflow or from the functional?
So, because the overflow would most likely, never say never, but most common in men because of the prostate, because you're blocking the prostate, right? And so you want to make sure. So, of course, a good history, very important, very, very important with good history, because a lot of times it's not clear cut with incontinence. And sometimes it's just, overactive bladder. And then for the neurogenic, of course, that could be like, it could be a spinal cord issue, not most commonly. Because for diabetes, it could be many different things, because high sugar itself is a diuretic. So when their sugar's high, they'll be peeing a lot. So one of the things that we really ask with people who have diabetes is, do you wake up at night? And how many times do you wake up? It's nocturia, basically. So, that's one of the things that we ask, symptoms that we ask when they follow up with us, because that's a red flag, would say, oh, your sugars aren't controlled. Yeah.
I guess in some of the cases with the water intake, right? So the timing of that. Now, the other problem is with as the age comes into the equation, disease like such an Alzheimer. So those patients do have. Actually, one of my family members is going through that problem, and it's challenging because the problem is that they forget that they eat or they already drink, and then they start drinking again, and they repeat the activity again and again. How is the treatment options, or what are your suggestions for that population?
A lot of times we give them a trial. There's many medications right now to see if that's going to help. But when we're dealing with Alzheimer's, the way that I think about it is like, when you're training your babies or your kids, when you're toilet training, you have to remind them, like, okay, it's time, make sure, so they're not having accidents. So maybe every 2 hours, every 3 hours, put a timer in. So just, it's a reminder, or if they if they have a cell phone, you could put a timer there. So it's just a reminder. So to me, it's just like potty training when it comes to issues like Alzheimer's. The other thing is, there's Myrbetriq, which is really good. In the past, you could either use both. Some urologists use both Myrbetriq and Vesicare as a combination, and that seems to work out pretty well. And with regards to coverage and side effects, Myrbetriq really is, I think, superior.
One of the things that I see, and I was just talking to Sean earlier, when we do our case conferences, we do deal with patients who have complications and high complex chronic illnesses. And one of the big problems that we see is the issue of these patients not actually getting enough support at home. And they're not in assisted living, they're not in a nursing home situation, they're home. And unfortunately, part of our culture here is that we have we don't have the same support. Like I know, like you are from Philippines, I'm from Turkey, and then dealing with our elderly population is different. So we do have more family support than here. So I think one of the problems that we are kind of seeing again and again is if the patient is not bringing this up. I think I do want to spend a little bit of time on this patient experience issue. From the patient experience side, like we have this embarrassment. I don't know if it's just me. I have close to 400 providers I work with, and 160 of them they are in the ACO, 180 maybe, and we still have this embarrassment when we have issues to bring up to our PCPs, our physicians. Now I'm going to be volunteering for this, and I have that problem. So if I have some problem, I'm going to do more Google search before I ask something to Dr. Garcia. So do you think that's part of the problem that patients
It could be, but the way that I present it, it's like, nonchalantly, it's like, oh, do you have headache? Do you have dizzy? Are you lightheaded? Do you have any chest pain, shortness of breath? Do you have problems urinating? Do you pee? Do you pee your pants? Do you, that's like the things that I do. So it's not like I'm intrusive, I'm being degrading to them. It's what I ask them, and it's part of what I do as a provider, as a physician. So it shouldn't be something that's like, oh, she's asking me because whatever. But so it comes out as a natural kind of question and answer situation, rather than more of a, oh, you're doing this or you're doing that. So when I'm talking about me, but so it's not like something that's intrusive when I ask them about those, about urination or about incontinence.
So we were wondering, like, the way the question is phrased, if maybe depending on the way it's asked by the doctor and then the way it's asked in the survey, because that is one of the issues that Kemal is talking about, is our patient engagement. So after patients have like their Medicare wellness visit, they do get a phone call, a survey, like from Humana or from United Healthcare or from Medicare. So the way I'm kind of looking at our book here. The way the survey question reads is, did your doctor discuss bladder control or issues with urine leakage? And kind of across the board, it's low, not just with our patients, but in general, with, like across the board, it's much lower than a lot of the other questions, like, could you see your doctor when you wanted to? That's a much higher number. So we didn't know if you had any thoughts about that and maybe the way it's asked.
I think so. I really do. Because if they mention the word bladder, I don't think it crosses that threshold between what the patient understands as to what the question is being asked.
Right.
Because sometimes when I say those things, they're like, what? What's your question? So they don't even get what I'm asking. So I say, do you pee your pants?
Right.
And
that's what I'm wondering is because of the way the question is phrased about bladder control or issues with urine leakage, if they're not hearing that exactly the way that is. So, that's one of the other things that we were looking at is there like a way, and also we're trying to send out some additional emails so patients do become more familiar with this and feel more comfortable about talking to their provider about those,
or just
those
maybe
kinds
like
of things.
Put a parenthesis below that, like examples, maybe, that's kind of things. Because if you say bladder leakage, I don't think they would necessarily think about that in terms of oh, I'm wetting my pants when I go to the bathroom, or I'm leaking a little bit, or
And
the
these are, I
schedule.
think, automated, like, because we don't do them. These are, put out by Medicare. But
Right.
certainly we've had conversations with the insurance companies in our monthly meetings, and part of that is they ask us, how do we address this with our patients, and do we have any ideas? So that's a good point, is you may be asking some of those questions about how often they go and different things like that, and they may not always be relating it to the way the question is worded in the actual survey.
Like, for example, do you wet your pants when you jump, when you do your exercises? So when I ask those questions to that patient, do they necessarily think that it's a bladder issue?
Right.
So they won't probably think about that, but that's what I mean when I ask those questions.
Right.
Yeah.
Or even the leakage part, or
Yeah.
so I do think sometimes it is the semantics, how we say it or how they're saying it, and putting that together. So I think part of it too is just making sure that the patients hear those things, that they become comfortable if they're uncomfortable, or as Kemal said, embarrassed about having that discussion with their doctor, but that it is important because one thing can lead to the next. So I know one of the things you had mentioned a few minutes ago was if they get up in the middle of the night, your concern is them falling, and that's like our next topic. So it kind of leads into that, where, we're concerned about fall prevention from a variety of perspectives for patients. So sometimes those things do go hand in hand, or they do, impact each other.
Well, actually, Donna, what you said is what I was about to just go into, because fall risk and the fall-related injuries is one of the most severe and the costly problem for the elderly population. Now, I was part of the trauma program for St. Francis Hospital in the beginning, so we had to do a lot of statistics, and 50+% of the trauma cases are coming from the fall cases, one-level fall cases. So 50%, a little more than 50%. Now, this, when Dr. Belson mentioned this night, getting up at night, and how that's linked to the fall risk, it's kind of like extremely, important from our point that this number, the fall increase, actually did increase. That's about 30% in the last 10, 12 years. Now, as this is increasing, the cost is increasing. But I think the biggest problem even before the cost is healing from this process is a lot more difficult for the elderly. So if they break a bone, for them to heal, it's going to be almost so difficult, right? So now, what can we do for what are the facts about the fall in the older adults, and what can they do? If we can just go through that a little bit.
Sure. So, I did pull out a few statistics out there from the CDC. So each year, millions of older adults, again, we're talking 65 and older, fall, which is about 1 out of every 4 older adults fall. But as you can see here, less than half tell their doctor. So it is one of the things, and I'm sure Dr. Bellasena will agree, it's part of that Medicare wellness visit. So one of the other things that's done during that visit is actually a screening about any potential, the potential for current falls or future falls, but also have they fallen recently, and then looking at those kinds of things. So again, what may lead to them falling? It can be, weakness. It can be medications that they're on that cause them to be, as Dr. Bellasena said, dizzy or have vision problems, or, a number of other things. It could be the vision problem. It could be foot pain. It could be home hazards. So that's also important to remember, that they want to have, hopefully not clutter, get rid of any items like loose rugs that they could trip over, other things laying on the floor, utilizing bars like around the toilet or the shower, things of that nature where they may need assistance, in standing from a seated position. Sometimes also making sure when they sit in a chair that it has arms perhaps so that they can help push themselves up or have something to hold on for stability. So again, one of the things that we want them to do is to make sure they are talking to their provider about those kinds of things so that an assessment can be done. And I'll let Dr. Belicena talk a little bit about that.
Yeah, so, part of the physical, or whether they're probably having problems with their back or having problems with their legs or just any ambulatory issue. One of the things that I check is when they're lying down and they push on their feet towards me so that I can feel how much strength they have basically with their thigh muscles, because that's what they use to stand up basically. And that's what I check. But one of the things that's really, I think, very revealing to me is I ask them to sit and I ask them to stand up. A lot of times they need to prop up themselves with their hands. And I said, what if you put your hands on your lap and then stand up for me? And most of the time, or like, I want to say between 70% of the elderly, and I'm talking about 75 and up, they have difficulty doing that. Mm-hmm. So then, I'll segue to that, but I usually refer them for physical therapy for fall risk and that sort of thing. But really, I try to explain, okay, you need to try to strengthen your core muscles. That way you don't fall, and strengthen your thigh muscles. In women, when I ask them about this, it's funny because I say, when you go to the bathroom, in public, do you sit on the commode or do you squat? So that's a revealing, answer, because when they squat, I notice that they're stronger, like they don't fall easily. Mm-hmm. It's because, they're able to do that. But with men, they don't necessarily do that when they pee. So I find that when they try to balance on one leg, it's a problem. They have difficulty doing that.
I think the main issue, one of the things that we really need to kind of remind ourselves is that I think preparing for those days, those years, now the population, the life expectancy is much higher than where it was 20 years ago, 40 years ago. Now, I think the projection of some of those people, they're like, well, I'm going to die before that age, so I don't have to really prep much. So it's not those anymore, right? So like even today, like when you hear someone who dies at age 75, you feel like that's too young, right? I mean, how many times do you feel that way? And it is. So then I think we need to really prep our population better for these days. So daily exercise is extremely important, and then they just need to walk. Keep them active, keep themselves active, and even with the small weightlifting activities at home, they can easily do that. Now, Dr. Belicena, I know you are actually seeing patients, and then we are okay if you need to take off.
Thank you.
Well, thank you so much for joining us.
You.
It's extremely important to have you. Thank you.
Bye.
Thank you.
Thank you. Bye.
So, Donna, like what I'm thinking is that even for the hobbies, and after the retirement age, some people, they are not ready because if someone retires at age 65, 67, let's say, then they are not dying at age 75. So Sean, you can come up. So he was hiding because we had so many people on the screen. So I think that's really important to prep ourselves and our elderlies for those times. Now, when I said 50+% of the fall, one level fall is the trauma cases, Sean, did you have any issue with that statement, or were you surprised?
I mean, having that severity with it, I mean, I don't think the broad population as a whole is aware of that. That might be a surprising fact that should you say that to, a random person walking on the street, I think, your average Joe would be shocked that it's that severe. A lot of people think, oh, you just fall and you get back up, you won't be sore for a day or two. But, when it's something serious where, you're fracturing a hip and, that's a pretty long recovery time, not to mention the physical therapy and, the slow process to get back to where you were, regain that functionality. So, yeah, I mean, it definitely was surprising, the severity of over 50% for sure.
Right, because their healing, like from a fracture, is certainly much longer than a young person. I mean, children, they heal very quickly. As you get older, it takes longer. And certainly when you're older and you may have, other bone issues, as people get older, sometimes their bones become more brittle. They have vitamin D deficiencies. So there are a lot of other factors that do play into that. And I do think, Kemal, what you were saying is doing the preparation. So staying busy, having some planned activities, sometimes, being involved in a group or doing some type of activity, even if it's once or twice a week. It doesn't necessarily have to be walking, but something that does, require you to move around a little bit, more than just walking around your home, or doing, small things within your home. That's going to be the way to continue with the strengthening. There's, different exercises. And I did want to mention that, here, one of the very first programs that Kemal had us create was a fall prevention program. So we do have that. We do review all of those screenings that I was talking about earlier, where we have one of our physical therapists in our network. He looks at those to evaluate them and evaluates other aspects of the chart to see if that patient would indeed benefit from a physical therapy consultation. And so he does do a host of, I guess in his consultation, he does, various different activities, kind of like Dr. Bellasena, where he's looking at how they're able to stand independently and things like that, and then recommends exercises that they can do from home. They don't have to stay into a long, drawn out, physical therapy program, but it helps them, and then they can maintain that, in the privacy of their own home, on a long-term basis.
Absolutely. So we have a couple updates left. So one thing that I do want to actually just point out, there is a first antiviral treatment for COVID-19 came out. This is now available. And then the other thing is,
I think it froze there.
Am I sharing the wrong screen?
Maybe I froze. Did I freeze?
I don't know. I'm going to ask one of the people. So if someone from our team can let us know who's frozen. I think I'm frozen, maybe. Usually John Donnelly lets me know, but I think maybe it was Sean. So no, it's not you. All right, so
It kicked me out.
it's same for Donna. So I don't know if I don't think I'm live, right? John Donnelly. So I think we are back on. Sean, if you guys can try again. All right, so while they are doing that, okay, so I think I should be all right. So, all All right, so the other guys I have my own connection, so they are having the issue, not me. So sorry, guys. The other thing is the fact check. Again, this is something that we are trying to bring up from Reuters. So it is, there is no reliable evidence of a link between mRNA vaccine and the heart disease. These are all bad publicity. Now, Sean and Donna, they got disconnected. So, and I think Donna is back. So while we are waiting for them, this is something that Sean perhaps for us now. Yeah. No, I'm live. Right? Yeah, I'm okay. So they are not. Sorry. They are. I think because of my internet being, sometimes it's a problem if I have my connection. I may lose the connection from my side. So now they're back on. Hey guys. All right. So we cannot blame Bill Gates for this one, right? So Sean, you are back.
All right, can you hear me?
All right, here's your cartoon. You wanna?
All right, back just in time. Yeah, so our political cartoon here, obviously you can see that they're saying you run out of Greek letters here. So obviously the gist behind this is the fact that with the new variants emerging, obviously we had the original COVID-19, we saw the Delta, and now we're having the Omicron. You know, it's kind of like a where does it end type thing. So we're kind
of the X, right? The next variant is going to be X. Is that why they're saying that?
Yeah, I think they're running out of options type thing where you know using up all the Greek characters.
People have way too much time to think about crazy Illuminati stuff, but it is what it is. Is this the queen, or is it just like any queen? Is it the Elizabeth II?
I don't know. That's Lady.
just so her.
I think it might be Lady Liberty, maybe Statue of Liberty.
That's too old.
She doesn't look too useful. I don't know who the dog is either, but
yeah, the dog is not hers for sure. Okay. So no, that's cute. Now we had a couple other slides, but because we are running late for the next session, so I'm going to stop here. Donna, thank you so much for joining us with Dr. Belsana on those clinical issues. Sean, as usual, thank you for helping us to make this possible. So I will see you guys later. Have a nice weekend, and we'll see you soon. Bye-bye.
All right, take care. Bye-bye.